great pleasure for me is to introduce our facilitator for today, Leslie Goodfriend. Leslie is Senior Health Services Manager at Santa Cruz County Health Services Agency, which, as we all know, here in Santa Cruz is known as HSA. Leslie has worked at HSA for 20 years, where she has earned respect and recognition for her intelligence and her abilities, and has been rewarded with increasing responsibilities. She began as a health educator in tobacco prevention, and later became a senior health educator in HIV education and prevention. Today, she oversees the chronic disease and injury prevention programs, the HIV education and prevention program, and HIV care services for HSA. Leslie received her master's in public health from the University of Michigan and then spent 2 years in the Peace Corps in Honduras working to support community health before making her home and her career among us here in Santa Cruz County. Finally, Leslie has been a skillful and inspirational leader during her tenure with the Regional Diabetes Collaborative over the last 5 years. She is now serving her second term as chair of the RDC. And to the chair falls the role of facilitating today's forum. So without any further ado, let's welcome Leslie Goodfriend.
Good morning, and welcome to the 8th Annual Diabetes Forum hosted by the Regional Diabetes Collaborative. As Kathleen mentioned, my name is Leslie Goodfriend, and I'm the chair this year for the Regional Diabetes Collaborative. For those of you who are newer to our organization, I'd like to share briefly with you what the Regional Diabetes Collaborative is. It was convened by the Pajaro Valley Community Health Trust in 2001, and then became formally convened as a collaborative in 2002. It's comprised of some 35 member agencies and organizations with a mission to support, promote, and coordinate efforts to prevent and manage diabetes in Monterey, San Benito, and Santa Cruz counties. And although I'm the chair of the RDC during the day, the rest of the day, I'm a Senior Health Services Manager in Public Health for the Santa Cruz County Health Services Agency. I became involved in the RDC in approximately 2007. I was trying to remember when I started, so I'm thinking it was 2007, because of the significant public health issue that diabetes is having in our communities and disproportionately impacting the Latino population. One of the things that most impresses me about the RDC is that this annual diabetes forum that brings together so many committed agencies and individuals to learn more about cutting-edge information related to diabetes management and education. And, you know, it's interesting when I think about, Watsonville, here we are, and we get to bring people from across the country, from Boston and from Denver to come and talk to us. It's a pretty unique and exciting opportunity, and I feel fortunate to be part of that. One of the other activities that the RDC does that I think is just great is the annual Diabetes Health Fair that takes place in the spring in the Watsonville Plaza, where people can get and receive free diabetes screening, referrals, and educational information. And it's a lot of fun, too, because there's always some kind of activity that youth plan and put on. So it's fun. So on behalf of the RDC Steering Committee, we're very proud to be hosting today's 8th Annual Diabetes Forum. This is a unique opportunity to learn and exchange information and best practices in diabetes prevention and management, and we always bring in high-caliber, exciting speakers from across the country. I'm proud and honored to be able to introduce Adam Spickler, who works as a senior field representative for Assemblymember Bill Monning. He covers local politics and policy issues relating to healthcare, education, social services, LGBT and civil rights issues, housing, seniors, public safety, and local government issues. I don't know how he does this all. As part of his fieldwork for Assemblymember Monning, Adam currently chairs the Policy Subcommittee for the Go for Health Collaborative. He's part of the Health Improvement Partnership of Santa Cruz County and the founding member of the Central Coast School Food Alliance. Adam is here today to present us with the information on an exciting piece of legislation that Assemblymember Monning has recently introduced, which is AB 669, which is the California Sweetened Beverage Tax.
Thank you very much for having me here today. I really appreciate the opportunity to be able to speak with esteemed speakers such as Dr. David Ludwig and Dr. Michele PACKARD and Leslie Goodfriend. I want to thank the Pajaro Valley Community Health Trust and the Regional Diabetes Collaborative for hosting this event today and for asking me to come and speak to you on Assemblymember Bill Monning's behalf. The Assemblymember really does wish that he were able to be here today. Unfortunately, he had previously scheduled appointments in other areas of the district. But it's an honor for me to be here to be able to speak to you about AB 669, the sweetened beverage tax. I want to give you some information about this bill briefly and make sure that you're aware of it, and hopefully that we have your support for this piece of legislation. This is not something that's an initiative that's going to be on the ballot similar to the way, or not similar to the way the cigarette tax was. What was that, about 10, 11 years ago? We had Proposition 10 on the ballot, and we now have funding that comes into the state through taxes on cigarettes that goes to fund children's health programs, and First Five of California. This bill, AB 669, would also levy an excise tax of 1 cent per fluid ounce of for every sweetened beverage with absolutely no nutritional value whatsoever in the state of California. This is something that's going to be presented to the legislature this year, voted on by the legislature, hopefully passed in both the Assembly and the Senate, and passed on to the governor, who we then hope will sign this piece of legislation. But the reason that I want to talk to you about support, and that we need support for this in the state, is that it has become a very partisan divide. Any piece of legislation in the State House that has the word tax along with it, there has been a no tax pledge that, and I don't mean to be speaking to you partisanly. There may be both partisans represented here today, and I certainly am not speaking in that regard. However, when we talk about the state legislature, I'm sure you're all familiar, there is a pledge that Republicans have taken not to ever pass anything that is a tax. Even though this piece of legislation, it would not go to the general fund. It's slated to build a very specific fund, and I want to make sure I name it right, so I'm going to look at my sheet. It would create the Children's Health Promotion Fund. It would be separate from the general fund, and it would go to support programming that we know is very likely to be cut with all of the other aspects of the governor's budget proposals this year. And the reason why it's so critical that we find an important way to fund these health programs, what we know and what you're going to be hearing, especially with Dr. Ludwig later on this morning, is how the adverse impacts of sweetened beverages with no nutritional value at all have impacted children, specifically children, but our health here in the state of California as well as nationwide. There's concern among high rates of childhood obesity, and it's preventable childhood obesity, driven by a 228% increase in caloric intake sodas and sweetened beverages, the consumption of which since the 1970s. And there is, let's see, the rates of preventable obesity in children between the ages of 6 and 11 years has more than quadrupled and almost tripled among children between 12 and 19 years of age. Obesity has dramatic impacts, as you all know, on the long-term health of risk of onset or preventable diabetes, heart disease, certain types of cancer, arthritis, and asthma. What I feel privileged to be able to speak to you about, and I know that's one of the reasons Assemblymember Monning has me speaking to you today, is I have personal experience with this. For those of you who've known me for the last number of years, you know that I've gone through a number of changes. One of those changes are I've lost a dramatic amount of weight. I'm one of those people who, as a child, I was raised in a house where the staple fluid was soda. I was raised drinking it and didn't know that water tasted good when I was growing up. I became an overweight adult, and it wasn't until I was diagnosed by my doctor with onset type 2 diabetes that I realized I needed to make a dramatic change in my life. It was a difficult process for me. I'm in great health now. I've learned a lot about healthy lifestyles. I've learned that I enjoy healthy food, and water is a favorite beverage, well, and coffee, but water is a favorite beverage of mine now. And I drink very little soda, and I would be happy, more than happy, to pay what will be passed on, likely, from the soda industry, a small amount more money to fund a children's health program when I do occasionally drink soda. But that being said, the other aspect that I bring to this is I also spent 14 years as an educator working with preschool age children, first as a teacher and then as a program director, and have worked with so many families who just don't have access to nutrition information, especially in the first 5 years of life. And we've all seen the occasional shocking moment when a parent is pouring soda or a no nutritional value sweetened beverage in a child's bottle, and the impact to their teeth, the impact to their immediate health, and the long-term impact it poses on not learning appropriate nutritional value and having nutritional information in their diets. And being an example of that myself, I couldn't be more proud, and I feel it's imperative for me to ask for your support. I know with all of you most likely living in either the 27th or the 28th Assembly District, you certainly have the Assembly members' support here. It's his bill that he's authoring. I have no doubt that Assembly Member Luis Alejo is also supporting this piece of legislation. For those of you who live in the 15th Senate District, it's critical that you contact Senator Blakesley and let him know how important you feel this piece of legislation is and ask for his support. And likewise, other health professionals that you know throughout the state, to contact them, give them information about AB 669, and let them know how important it is to contact their state representative and let them know that their vote in favor of this bill is critical, not only to help curb the consumption of sweetened beverages by children, especially in the state, but to help build this fund that will go to fund programs that are likely to be cut. So I have more information about AB 669 on the back table in the area where all the name tags were when you first walked in. I also have business cards with me that I'll leave back there. If you have any questions or you would like to sign on as a supporter of this legislation, please feel free to contact me in the office. Be happy to pass on your thoughts to Assemblymember Monning and sign you up as someone who's in support of this legislation. I want to thank you very much again for having me, and I really appreciate being here as well this morning. So thank you.
Our next session is the first part of a two-part session entitled Motivational Interviewing in the Management of Diabetes, Preparing People for Lifestyle Change. Dr. Michele Packard is the Executive Director of SAGE Training and Consulting, which is a national continuing education company providing evidence-based training since 1983 to substance abuse, behavioral health, and healthcare professionals. Dr. Packard is on the adjunct faculty at the University of Denver Counseling Psychology program, and please join me in welcoming Dr. Packard.
Good morning, everyone. It's a great treat to be able to be with you here. Buenos días, señoras y señoritas. Estoy muy a gusto de estar aquí en el pueblo de Watsonville, especialmente porque estuve aquí este verano para la feria. So I was saying that I had the opportunity to be here for the fair this summer, and one of the incentives for me to come here and be with you is that it has the nice side effect of being able to visit 4 children in the Bay Area. So you're making my week. And it's also an honor to be able to follow in the juicy, possibly gluten-free slice of Dr. Ludwig that you got for breakfast. So I'm thinking of myself as maybe the mid-morning snack of fruit and yogurt and nuts in this conversation that we'll be having on motivational interviewing. My goal in today's talk is going to be to give you a series of tips on how you can increase motivation and decrease resistance in a conversation with your clients, so that you basically aren't working so hard in your work with clients. And this is based on the work of William Miller, who is the co-author along with Stephen Rolnick in the original motivational interviewing text, the second edition of which came out in 2003. And then in 2009, they came out with the text that you have here. It's motivational interviewing adapted and applied specifically to working in the healthcare field. And Stephen Rolnick, who's the co-author and the lead author in this text, is a psychologist who spent his entire life working in the healthcare field. And by the way, I wanted to say some nice things about Dr. Ludwig's book, and I was already getting ahead of myself. For those of you that haven't read Dr. Ludwig's book, I've got it here also. You can take a look at it. I noticed that he's been very humble about it. I don't see any stacks of 100 books there in the back for you to buy. If you haven't read the book, it's a very wonderful book. I appreciated it very much, especially the clear compassion that he has for his patients. And you'll see throughout the book, he gives numerous examples. Well, he's basically a natural at motivational interviewing. And throughout the book, he gives numerous examples of one of the basic principles in motivational interviewing that's called roll with resistance. So that if somebody is trying to fight you, and he gives this wonderful example in the book of a 10-year-old boy coming in with his mom to the office to attend the OWL program, and the little boy doesn't want to be there. So instead of getting into a power struggle about that, with mom being the ally, yes, you have to be here, and then Dr. Ludwig trying to make himself invisible, instead he very strategically places himself in the interview and gives the boy an option. So he tries to negotiate an agreement for change. And so he says, well, what about if you just might be willing to be here just for today, and if we agree that if you don't like it and you don't want to come back, your mom and I agree that you don't have to come back. So that's called leaning into the resistance. So given that kind of choice, the boy says, oh, all right. You know, who knows what his tone of voice was. And lo and behold, he completes the day and goes home and is willing to come back for the program. So roll with resistance is a really important principle. Now, what I'm going to do is, well, basically the first tip that, or let me back up a step. One of the things that Bill Miller doesn't give himself total credit for is that he shows you throughout the motivational interviewing work how to use the client's energy for change rather than your energy for change. And so one of the things that I noticed from giving talks to healthcare providers, myself included, is that here and there in a conversation, you'll notice that you're working harder than the client, or you're getting exhausted sitting in a room with a client, or you're beginning to be tired just thinking of going to go see somebody because you already know which way the conversation is going to go. So the first tip is to do a little laparoscopic brain surgery into your frontal lobes and see, because I have to do this all really fast today, but I'm going to be giving you tips that we usually sprinkle into a 3-day training. But the first one is if you can scrub a dub out of your brain 3 words. And the 3 words, to just kind of put some babbo on it, are resistance, non-compliance, and denial. If you can just like gently give yourself a little massage, and it's got some babbo under your fingertips, and instead reframe that as the client being ambivalent about change. So the central organizing principle in motivational interviewing is management of the client's ambivalence about the change process. And if you, so it's the reason I'm saying to engage in this scrub-a-dub exercise is because the way that we think about somebody drives the way we respond to that person. Yay or nay, do you think? Yeah. So if we think of the person as being resistive, in denial, or non-compliant, right away, that's a situation where you're going to start to feel worn down. So instead, if you think of it as, oh, the client is ambivalent about change, of course, ambivalence about change is normal. We're all ambivalent sitting here in this room today about the health changes or lifestyle changes that we're thinking of making in our own life to take our own health to the next level. What that does for you is it lends itself to thinking and conceptualizing in terms of a lot more friendly set of interventions that are going to help you build the relationship factors in a conversation. So that's one thing that I'm going to talk about. But then if you're able to, whenever you're listening to the client, and so the other thing that I wanted to mention and thank you for is that prior to today's presentation, we did a needs assessment survey, and I asked the señorita Raquel to ask you, what are some of the difficult situations that you feel where you feel stumped in a conversation with your clients? And you were all very generous at providing, those are what I call stumper statements. So what I'm going to do is weave those into the conversation today and use the material to show you how you would work with those particular issues. So the first way to work with it is this business about reframing resistance as ambivalence. And so that whenever you're talking to somebody, you're automatically looking for ambivalence. So as long as we're on this subject, if you would be willing, and let me ask your permission, would you be willing to try something that would be only in your mind right now with me? Okay, I'm doing another motivational strategy, which is asking for permission. It turns out that psychologically, if you ask somebody for permission to say something to them, they're much more likely to say yes than if you launch into it without asking permission. So think about anything that you're thinking about changing in your life that would be a lifestyle change, since we're on the subject of healthy diet, if we're not, you didn't tell us how to replace the word exercise with something more positive, Dr. Ludwig. Is it movement or fun activities or something like that? But anything that you're thinking of doing in your life that would improve your healthiness of your lifestyle that you haven't done yet. And are you able to think of something as we're sitting here this moment? Don't look at me scared. The good news is I'm not going to ask you what it is. Okay, and so then as you did that, isn't it the case that you noticed some ambivalence percolated up to the surface? That there's a part of you that's thinking, yeah, I want to do this, and another part of you is thinking, ooh, but not today. Yay or nay? Okay, so the first most wonderful thing that you can do in a conversation with a client is ask them about the part of them that wants to and the part of them that doesn't. So for instance, some of the things that you said is that our challenges are when the client says, oh, I can't exercise because my knees hurt, or it's too cold outside, or I can't eat a healthy diet because I can't afford it. So in motivational interviewing, rather than be stumped, you would say something to the client very positive. So you're always trying to find avenues, ways of getting your foot in the door. And by the way, that's another thing that Dr. Ludwig is very good at. He didn't show you this. I think that you should actually do that in your presentations. He's got a million examples in the book of like the skillful means that he uses to get his foot in the door with a patient to allow him to do his magic. So one of them is, the client, so here might be an example in motivational interviewing. The client says, I can't exercise because it's too cold outside. So in motivational interviewing, you might say, wow, sounds like you've thought about it. Great, good for you. I'll be interested in hearing what kind of thoughts you've had about it. See, so you're always going on the basis of affirmations, and that's another one of Dr. Ludwig's strengths, and why I'm saying that he's a natural. Throughout the book, he gives examples of ways that he affirms the patients, anything about their attitude or their intention or their past efforts. He wraps an affirmation around that. So great, good for you. It sounds like you're thinking about it. But the way that your tone of voice just now sounds like there's a part of you that wants to, but maybe there's a part of you that doesn't want to. And then you're looking at the client, and the client is saying, you can tell they're nonverbals. Yeah, there's a part of me that doesn't want to. Well, how about, and you can tell that maybe the majority, by their nonverbals, that the balance is tipped against change. So then you lean into the resistance by saying, well, tell me what seems to be so horrible about making this change. Or tell me what might be some of the pluses and minuses of making this change. Now, the thing about us healthcare providers, and usually I set this up and take more time with it, but because I don't have the time, I'm going to have to just give it to you this way. It might be a little bit sharp, so may I have another little bit of permission to say something in the way of feedback about ourselves? Well, I'll put it in the form of a question, which is, can those of us that are sitting here in this room today, all of which of us work in the healthcare field, can we recognize that we tend to be a group of people who are walking around in this life cycle, probably with an invisible helper hat on? Yay or nay? Oh, no, yeah, okay, you got over it, right? You're cured, you're in recovery, you're attending a self-help 12-step group for people with invisible helper hats. Okay, so not to worry, there's a lot of suffering out there in this world, so somebody's got to be out there helping. It's just that I'm going to show you how it works against us sometimes. And one of the ways that it works against us is that we tend to be cheerleaders for change. So kind of park that idea in your head, and I'll show you how that's going to play out in an interview here in a minute. So going back to ambivalence about change, if you can just think about whatever it is that you're thinking about changing health-wise in your life as you sit here this moment, and you can just gradually let your brain accept that idea and create some neural pathways so that concept of ambivalence pops up into your mind the minute you're in a room with a patient. What that'll do, besides relaxing you a little bit, is it'll allow you to go to the next step, which is to begin to identify the traps that'll make you work too hard in an interview. So the traps are usually having to do with moving too soon into problem solving and advice giving before the patient is ready for that. And actually what it does is it actually creates the opposite effect, where the client starts to dig in and say, yes, but, yes, but, yes, but. So a number of you were saying, well, what do I do when the client says yes, but, yes, but, yes, but? Well, and then the other tip is, once you start to recognize those traps and you start to avoid those traps, then the next improvement in your motivational interviewing skills is you can start to more accurately recognize and hear in the client's language use of words that are tips to their motivation for change. So the newest research in motivational interviewing shows that by listening to the client's language, you can actually predict who it is that's going to make changes. So basically, if the client expresses a desire to change or confidence about changing, or if they express reasons to change or a need to change, those are all your internal clues that there's motivation to change. And for those of you, the perfectionists in the room, I promise you there's a slide that shows that, so you don't have to remember that so far. I'm just giving you an advanced organizer. Because so what you want to do in the conversation, instead of going down the road of challenging the so-called resistance or non-compliance, look for evidence of desire, ability, reasons, or need to change. Okay, and then have that conversation, because it turns out that the more the client expresses change talk, the more likely they are to change. So, okay, then the other piece is to make, the other tip is to think of every single conversation that you have with a client as a potential brief intervention. So I'm going to show you 6 ingredients that you can use to package each conversation with your client that have actually been also shown to increase motivation for change. But in the book, when Dr. Ludwig gives the example of the little boy, the 10-year-old who doesn't want to come for the OWL program, what he did right then and there, he did a little brief intervention. So the brief intervention, you assess where is the client at now. You explore a little bit about their ambivalence. So you saw that there was some sort of dynamic that was playing out in the mother-child interaction, but then he paused and he moved right away for this third step on agreement for change. And so that was a brief intervention right then and there that enhanced motivation for change. And the only change he was looking for is change to get the boy to agree to come to the next appointment. Because if he didn't put his body there, then there's no magic, that you can do. So there's always, your first goal in motivational interviewing is always to engage the client to take the next step. So in today's conversation, let's think about it that every communication that happens, regardless of whether it's you and your patients, it could be you and your husband or your wife or your coworker or somebody that comes to your house to do some work for you. Every conversation is a communication on 2 levels. There's always the content or the spoken level of a communication, and then there's the process or the unspoken level of the communication. And one of the traps is to get too bogged down in the content. I don't want to be here, or my knees hurt, or I don't have the money to buy good food, and get into sort of like an argument about it. And if you get into a power struggle about those kind of issues with a client, I'll bet you know from your experience who's most likely to win that power struggle. The client is. Who's got more energy for it? The client does, yeah. So instead, and I'm kind of a control freak, so it's easy for me to notice myself getting into a power struggle. But one of the things that I do is whenever I notice that I'm in a power struggle, you can always back off and start again. So you never blow, the good news is you never blow it in a conversation with your clients. So we have the idea then so far that in every conversation, there's doors that you can open and doors that you can close. And so what we say is that motivational interviewing, the definition of it is that it's a patient-centered, but provider-directed or interviewer-directed way of working with patients. So what that's saying, in the examples that you were able to send me via email, I saw without a shadow of a doubt that as a group, you're very patient-centered. It was very clear that you're committed to patient-centered work. You gave it interactional examples of where you asked the patient, what do you think might be the next step here? So that's not something, that I'm worried about. The thing that I think can provide value added for you in motivational interviewing is how to work more effectively with the process. So think of it, sometimes it's a little bit harder to think of ourselves as being very skilled technicians, just the way a surgeon is a very skilled technician at doing what the surgeon does. We're also very skilled technicians in the communication process. And so that we can manage the conversation and manage and direct what kind of doors we want to open and what kind of doors we want to close. So meaning what kind of doors are going to increase motivation for change and what kind of doors are going to cause you to more likely get into a power struggle and reduce energy in the conversation. So when we talk about ambivalence about change being central, here's an example of how this might play out. So we gave the example of the client saying, well, you guys tell me something else that the client might say that indicates you think that they don't want to change. I can't do it. Who said that? I can't do it. Well, okay, because I just want to make eye contact with it. You. Okay, you can't do it right now. Wow. So it sounds like you're thinking about doing it, but not instantly. Great. So what are your thoughts about doing it? See, I ignored the not right now part because it's a dead end. It's a lose-lose for me. If I go down the drain of talking about the not right now, she's going to wear me out and wear herself out. And here's some bad news. Can you stand? May I have permission to give you maybe only one piece of bad news today? Actually, I didn't even have it in my talk, but I just reminded myself of it right here. Yay or nay? It's not awful. It's not Iraq or Afghanistan or... I don't know. As a group, you seem to be a little bit ambivalent about that. I can see there's a part of you that wants to and a part of you. So yay or nay? Oh, and by the way, it's not a piece of bad news about you over here. The bad news is that the more the client says, no, so what did you say? You said, not right now. The more the client expresses not right now, that's called no change language, or those of you that have had training in motivational interviewing, sustain language, which I think is kind of technical, and I'd rather just describe what it is. The more the client expresses in their language no change, no, I don't need to do it, no, I can't do it, no, I don't have the time, or yes, but, unfortunately, the more they're actually talking themselves out of doing it, and the research has now shown that the less likely they are to do it. So that's a door that you definitely want to close. Now, you honor the client. You don't discount that they said not right now. I'm not going to go and slap her around and say, well, no, right now. Let's talk about right now. Because that's going to create, in fact, that's going to create another problem. Okay. So the nature of ambivalence is that people are guaranteed to feel two different ways about the change process. So when she says not right now, then I might say, wow, sounds like you've thought about it, but you're not sure that now is the time. And then I'm looking to see if her nonverbals are kind of positive or still kind of negative, but she was a little bit positive. She nodded her head. I won't even count the smiling and laughing because I know I put you on the spot and you're nervous, so I won't give myself credit for that. But then I'll follow up, but the way that you were looking just now when you said that, and so I'll try to kind of drop the tone in the interview, make it a little bit more intimate, and I might say, as if this is the first time in my whole life that I ever noticed this, I have the feeling that you feel two ways about this. And then I'm looking for the nonverbals, and she's looking at me attentively, so that's my green light to go ahead. There's a part of you that sort of would like to maybe get going with exercising a little bit, but there's another part that's really got some doubts about it. And then she's nodding at me. Okay, now she didn't really look overly enthusiastic, so that's going to be my yellow light. She's worried. So then I might say, well, now I'm going to ask permission again. I'm going to say, how about if we brainstorm some of the pluses and minuses of this for you? I've only been using the word brainstorm in the last couple years, but it works like a charm. I thought at first it was too abstract a term, and a lot of people would say, like, what? What are you talking about? It turns out even the most impaired person, when you say, how about if we brainstorm, motivationally, they know that you're not asking them to commit themselves to change. So that's another example of working with the process rather than the content. So I say, well, what about if we brainstorm? And then another added piece is for a couple minutes. And so, maybe you have a person who's kind of pissed off and hostile and thinks you're a pain in their day. So you say, well, what about if we brainstorm for a couple minutes? And the client is thinking, oh, a couple minutes? Okay, I can handle a couple minutes. So then, resistance goes down another notch. what about if we brainstorm just for a couple minutes, the part of you that wants to, but the bigger part, it looks like, that doesn't want to? And so what you're doing there is you're eliciting their ambivalence about change. And by doing that, that is the number one that's the number one factor that's going to build the potency of the relationship. So one of the goals for the workshop is to give you the three factors that build, the three relationship factors that will increase motivation and decrease resistance. One of them is to move the issue of ambivalence center stage. So you'll see clients actually visibly relax just a little bit in their seat when you say to them, tell me about the part of you that wants to and the part of you that doesn't want to make this change. Now, that doesn't mean that, and so that you can see them relax a little bit. Now, does that mean that they're going to dash out the door and make that change right away? No, you don't have to pretend that the model is that magical. No. But what if they relax 5% compared to the way they were 10 minutes ago? Is that worthwhile or not worthwhile? And does that have the effect of creating the possible teaching opportunity for you to do some of your magic? Okay. Now, the other thing to be aware of with ambivalence is that there's a certain dynamic to the way that us people with an invisible helper hat manage the conversation with our clients. Okay, so here I apologize. Now I have one more piece of bad news. Can I give you the piece of bad news, or should I try to all put it in the positive frame since it's a beautiful day, there's no snow on the ground? What do you think? Go for it? Okay, but still there's some ambivalence there naturally. It's normal to feel ambivalent. Of course you feel ambivalent. But the bad news is that us people with an invisible helper hat tend to be cheerleaders for change. So we tend to say to our clients, rah, 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 the benefits of change. Modify your food plan, throw out all those simple carbos and processed foods, although I got motivated. If you read the way Dr. Ludwig presents it, it's amazing. I got motivated to do it. What else do we tell them? Exercise, it's going to be great. I notice you don't do cognitive behavioral. You don't tell them, and while you're at it, change the way you think about yourself and your life. And it's going to be great. And how do you think the client reacts? Yeah, right. The client goes to the exact opposite side of their ambivalence and starts digging in their heels and telling you all the reasons not to change. So we say that a lot of so-called resistance is actually iatrogenically induced by the interviewer's poor use of skill, that we actually cause a certain amount of resistance by actually reinforcing it, opening that door, getting into a power struggle about it. So poor use of skill, not managing the conversation very well. And the sad part is that the more that the client resists, the more you're going to see this kind of effect of a mule digging in, no, I don't want to do it. Or I talk about this, the ostrich problem with my clients. Oh, and by the way, I don't anymore tell my clients that I think they're in denial. Because how do they react? Do you think they react with, oh boy, thank you for telling me. I didn't realize that was what was going on. I can't wait to carry on with my life now. Is that the way they react? Or is it a little bit more like, go to hell? So that's like another no, right? And when you did that, did you increase motivation in the relationship, or did you decrease it? Decreased it, yeah. So instead, sometimes when I'm sitting with a patient in the office, if the relationship feels kind of good, I'll say, I'm getting some ideas about you, but I don't know if you're interested. And even, your most pissed off, hostile client, if you say, but I don't know if you're interested, what are they going to say? Tell me. Okay, now Bill Miller is an extremely respectful person. He wouldn't do what I'm telling you now. Personally, I'm a little bit more aggressive, and I do think I need to work on it. But anyway, what I'll do is I'll use the dynamics of ambivalence to work for me. So the client looks at me, what? And so I say, oh, no, you look like you're having a bad time today. I'll tell you tomorrow. So see what I did? I went to the other side. And so then the client, what are they likely to say? Tell me. Then if I'm feeling really sadistic, I might say, no, you're going to throw tomatoes on me. I say, tell me. And then if I'm really on a roll, I say, no, I'm kind of a chicken shit therapist. I don't know. Oh, excuse me, I wasn't supposed to say that. Okay, blip. Oh, how could I? And I'll go home and tell my husband I used a bad word, and he'll shake his head at me, and I'll have half my rest of the month ruined. So I'll say, no, I'm kind of a chicken therapist. And so then the client says, no, tell me, it's okay, I can handle it. And so what you're doing there is you're working with the dynamics of ambivalence in your favor, and you get the client to basically beg you to tell them the very thing that they had no intention of hearing in the first place. So, okay. Now, Bill Miller, there's no way that he's like that. So if you see Bill Miller, don't be surprised. He would say very respectfully, he's very low-key. He's more like Dr. Ludwig, I think. He would say, I've got some ideas, but I don't know if you're interested. And he would skip the add-ons. So I'll say that this part of the, request that this part of the presentation be confidential, and you not tell him if he has a chance to make his way through this part of the world. So if you've got the idea of ambivalence, and I can see that you're clicking into that concept, that whoever we're working with, that you're always ambivalent about change. And the reason that we know without a shadow of a doubt that ambivalence is normal is because we're ambivalent about changes in our life. So, the first piece of ambivalence that I'll feel in the morning is when the alarm clock rings. And I already go into this little chitter-chatter in my head about, oh no, it's time to get up. And then, hey, what about all those thousands of hours of cognitive behavioral therapy you've had? Oh yeah, I can't wait to get up this morning. And see if that makes me leap out of the bed. Instead, I kind of stagger to the bathroom, scrub it up my face, and then I get a little blip of self-confidence and scrub it up your teeth. Oh, I feel a little bit better. Then I visualize a cup of coffee up the stairs, and then finally, you start to forget about the whining in your head, and off you are in your day. Okay. So if you've got that, so to be human is to be ambivalent. We all are ambivalent about everything in our life. So the getting up, most of us know we're going to get up no matter how much whining we do in our head. But we could avoid a certain amount of pain by skipping that whining. I'm talking to myself right now, but since I have many long years of reinforcing myself for it. The trap, this premature focus trap, is the one that I mentioned a little bit before, and that is moving too soon into the change process. So, for instance, the client, you give them feedback, and by the way, you already are set up in the most wonderful way to have a motivational interviewing with clients, because it looked to me that in the vast majority of cases, there's going to be an assessment that you're doing with the client, and that then you're going to give the client feedback on the assessment of lifestyle, assessment of obstacles, that sort of thing. Yay or nay? Or you keep your assessment data to yourself? You give it to the client, right? Okay, here's another motivational tip. Always ask permission before giving assessment data. So or the easier way of thinking of it is always ask for permission before giving feedback. So, Miss So-and-so, Miss Raquel, I have the results of your blood work. I'm wondering if you'd like to go over it today. So you're asking for permission to get your foot in the door. 90% of clients are going to do what? They're going to say yes. But the thing is, they said the word yes. As opposed to, Ms. Raquel, would you mind coming over here and having a seat? I've got something to tell you, and I want you to really pay attention. Now, I see this, and I see that, and I see that. Is that going to build much of a relationship with her? No, not exactly. So always asking for permission to give feedback. But then what I noticed in some of the examples that you gave me is you went immediately from the feedback to trying to solve the problem. So I'm wondering, so you gave me examples, well, what about doing this? Or what about doing that? That would be an example of premature focus. Instead, in motivational interviewing, you ask an open-ended question and you say, well, what are you thinking about the feedback so far? Because you're working towards building a collaborative relationship. So that's the second factor that builds the potency of the second relationship factor. So the first one is honoring ambivalence by talking about it, find out about the part of the client that wants to make the change, the part of the client that doesn't want to make the change. The second relationship factor has to do with moving in a collaborative way with the client. So what do you think about the feedback so far? And so then the client is engaging with you. And some days, if I'm feeling a little bit depressed, I hate to say this, but I feel like car salespeople know more about motivational psychology than we do. Because if you've had the misfortune of having to buy a car lately, you sort of know how they work and it sticks in your brain forever too. But like, they know that you want a 4-door car, but they've only got a 2-door car. But what's the very first thing that a car salesperson says to you when you go on the lot? After they say, hi, I'm so-and-so, what's your name? Shake your hand. Oh, it's a nice day today. And then what? What are you looking for? Oh my gosh, they're collaborative. I can guarantee that they've learned that strategy in marketing classes to begin to rope in their fish. So they're asking you, what do you want? Okay, so when we say to the client, well, how are you reacting to this feedback? Right away, you're getting, whatever they say, they're going to give you very juicy information that you're going to be able to milk for motivation for change. So do you want to give me an example of something a client might have said? Not your client from hell, but maybe your medium hard, because I know in a presentation like this, you'll want to tell me all your worst. But then I'll go home and I'll be all totally depressed because I haven't been brilliant at showing you what to do. So like a medium hard, what might somebody say in response to feedback about their blood work? And the diagnosis also, by the way, of being diabetic and having a diagnosis of diabetes. So the client says, I don't understand why it is the way it is because I've been doing a lot of everything right. Wow, so the good news is, sounds like you're really motivated to do the right thing for yourself. Affirmation. Then, open question. Well, so that she says she's done positive things. That's the door that I want to open. Well, what kind of things have you done for yourself? Because you probably have. How about if we brainstorm that for a couple minutes? And so then she brainstorms. And then, well, what is it that is, now, you know that whatever they say, there's problems. Because like Dr. Ludwig was really good about showing even those of us that think we're doing pretty great, and I'm afraid that I'm one of those ones, I thought, one bagel in the morning isn't too bad, is it? And in the book, he's even more convincing than he was this morning. He says, if you have any doubts about a bagel turning into straight sugar in your body, just chew a piece of it for a while longer in your mouth than you're used to, and you'll start to taste the sugar breaking down. It's like, oh. So, but being oppositional defiant, I had to go get a bagel this morning, my last bagel of my life. Unfortunately, I was kind of grouchy because it wasn't the best bagel. It was a Starbucks bagel if it was going to be my last bagel. But anyway, so I've already done a lot of the right things. It's going to be a case. You're going to find out that there's things that they aren't doing, but don't bother with that right now. Affirm them, increase the their confidence, build on the relationship factors, and then explore a little bit of the ambivalence. Well, what is it that seems to be the hard part about taking this to the next step? Because we know that managing your lifestyle for healthy lifestyle is not a one-time thing that you do and then everything's okay. It's a step-by-step process. So what's keeping you from taking things to the next step? And for this person, they say, I've done everything right. Do you think that the balance is tipped for change or against taking the next step? Well, the way she said it, is she motivated to take another step? She's motivated to maintain probably what she's already doing, but is she motivated to try something new? Okay, it's more tipped against change. Okay, so then lean into the resistance. Instead of saying, rah, 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 how about trying whatever? You say, oh, no change. What is it that makes it hard to take the next step? And then she tells you what it is that's making it hard. When the person tells you what it is that's making it hard, the no change, the part of them that doesn't want to take the next step, they are giving you extremely juicy information that adds up to the obstacles to change. So it's essential to know what those obstacles are to change if you're going to intervene effectively with that person. Now, here's some good news about being a cheerleader for change. May I have permission to tell you some good news about being a cheerleader for change? So you say to this patient over here, well, what is it that keeps you going? What is it that's been worthwhile for you to make these changes all together? And when they tell you the positive parts about change or the benefits they're getting from change, those add up to what Dr. Ludwig calls the reinforcers for change. It's absolutely essential to find out what is it from the client's point of view, so not from our point of view. We're motivated for healthy lifestyle and all the wonderful side effects of healthy lifestyle, but what is it from the client's point of view that would motivate them to take the next step? So when you ask them the pluses and minuses of change, that is going to elicit that kind of information. Now, the reactance effect is the effect that happens when you tell somebody to change. So come on. Oh, so the thing that I'm thinking about changing in my life at this point is I'd like to lose 20 pounds. So I thought this was a very timely place to come and hear a conversation and a talk from Dr. Ludwig about this. And unfortunately for me, my husband is also motivated for me to change. And then doubly unfortunately, I already tell you, I'm oppositional defiant. So, he gets up in the morning. I still, like a couple weeks ago, he said, oh, are you going to Weight Watchers today? I mean, I love my husband and everything, but was he cheerleading change or was he leaning into my resistance? I didn't go. Now, you'd think that at my age I'd be a little bit smarter about what's in my best interest. I wasn't going anyway. I was too busy, but it did kind of. That's right. Yeah. Okay. Don't laugh about that. Okay. I'm too busy. Oh, okay. Great, Michelle. Sounds like you've thought about it and you've got an idea of when to go. Oh, now I found myself so entertaining. I forgot where I was going with that. But anyway, telling the patient what to do is definitely going to build that reactance effect. So, tell me what kind of questions you might have, how you're thinking about this in terms of implementing some. The good news is the vast majority of the changes that you might make in a conversation with a client are chiropractic changes. If you like the motivational interviewing approach, it's not a matter of major surgery, it's a matter of chiropractic adjustments in what you do. So you don't have to throw away things that you already have in your toolbox that work. It may be just a matter of improving the timing or improving the placement of that intervention. So, okay. So, but what kind of thoughts are you having, or ambivalences, or I hate the very idea of what you're talking about here. Now, because it's not the 3-day class, I'll just give you the soundbite version that, in motivational interviewing, they really steer away from the word confrontation because it's in the addictions field, we've used it in a hostile way that actually increases resistance. But if you use the word in the way that James Masterson uses it, who's one of the experts in interviewing difficult clients, he says if you define confrontation as bringing something to somebody's attention, then yeah, our clients need all kinds of things brought to their attention because they either have their head in the ground or they've got blinders on or whatever it might be. So one place you're bringing something disagreeable to their attention is in the very beginning when you're giving them feedback on the results of the tests that you've run. And that's another reason, by the way, to ask permission to give the feedback. And then as you're giving the feedback, you're building on the relationship factors. And then, down the road, you might, and I know that you do, you might very respectfully say, and this is potentially a life-threatening thing for you. So and maybe you'll punctuate it with that. So I'm wondering how you're reacting to what we're talking about today. But you're also bringing up another question that is a good one because since a lot of people here are diabetes educators, the question always comes up about when's the right time to give somebody information and feedback. So definitely when the person asks for feedback, you've got your real window of opportunity. But then the question is, what if they don't ask for feedback? So after lunch, I'm going to talk about the 6 stages of readiness for change. But the one place that's not likely to get very much bang for your buck is when the client is at the pre-contemplation level. Stage where they say, I don't have a problem. I don't need to make any changes here. Because it's just going to be like water off a duck sort of thing. So, okay, other questions? What was the one of you asked Dr. Ludwig the question, you said the client, what do you say to the client who says, I got diabetes as a result of a trauma, and I went to the it gave me a pain in my tummy, and then I went to the doctor, and the doctor said that I had diabetes? So from the motivational interviewing point of view, who was the person that said that one? Because they ran away? Oh, okay. Well, thank you for that one, because that was very juicy. So in that case, you know that they've probably put cause and effect in the wrong order. So for instance, they did have the trauma, it did give them stress, they did get the pain in their tummy. The pain in their tummy motivated them to go to the doctor. Maybe they haven't been to the doctor in 5 years. Now the doctor finds out, there's this condition that's been going on for longer than that. But we don't bother. Is that a conversation? Oh, no, you're wrong. It wasn't because you had the trauma of seeing this thing. It was blah, blah, blah. Is that going to be very well received? No. Instead, affirmation, or maybe a reflection. Oh, well, I'm sorry that you went through that, as genuinely as possible. And, well, no, I know because we've been laughing, but I mean... And also that it actually, isn't it interesting the way it actually gave you a pain in your body, and that pain motivated you to go to the doctor and see how you're doing. That was great. Good for you. I'm sorry that you found out about the diabetes. But maybe better now than later. See? So you affirm, you don't get into a struggle about, no, that's not the way that happened. Find the good news in what the person is saying and then use that as the opportunity to get your foot in the door. So I think you're kind of clicking with that, get your foot in the door ideas. So what do you say if somebody says, you say, what's making this hard for you? And they say, I don't know. You mean sort of like an adolescent? I don't know. I don't know. Oh, here's a good one. Okay, well, first of all, you contain your homicidal impulse, which of course you only have on a bad day. But, well, see, because you know why? There's this thing called the parallel process. Sometimes that I don't know. When we talk about all communication being on two levels, there's kind of a hostile undertone to it. And us people with an invisible helper hat are prone to sponging up positive, well, no, we'll sponge up positive things, but we're also prone to sponging up negativity. So that's why I was saying, not that I think, you're at risk of something serious here in the community. But so the person says, I don't know. Okay, there was really a nice study that came out last year in which there's an instrument that the World Health Organization has a series of questions that you can ask people with diabetes about what their worries are about their diabetes. And I thought, wow, what a great way to get your foot in the door with a pre-contemplator. No, I don't have a problem. Or somebody who's not, see, that person isn't giving you any. In fact, that person is very good at closing the door in your face. So then I might, if I'm feeling pretty good, I might say, well, it's very common that people have worry. Once they are told that they have diabetes, it's very common that people have worries about their condition, but I don't know what the worries are that you might have. So you try again very gently. If they bring you just one worry, that's an incentive, operating for change in the conversation. So I'll just finish with this little story about, I had a client that was really good at closing the door in my face. He wasn't diabetic, but he did have a lot of gastrointestinal problems. But the reason he got referred to me was because he was on his third drunk driving ticket. And he was this 20-some-year-old guy. He had a certain amount of talent, worked in the telecom field, but the way his appearance was enough to make you pass out. His hair was dyed yellow, spikes. He had rings in every part of his body, every visible part of his body, to such a degree that it was impossible to not wonder about what invisible parts of his body had these, and his pants always drifted 4 inches below the bottom of his feet and way down below his waist. And so he didn't exactly present himself in a very positive way, but he was a likable fellow. But he was, no matter which way I would go at him about his drinking, he would close the door in my face. And finally, one day, when I said that you never blow it in a conversation, finally I realized, Michelle, you could practice what you preach. Here you are cheerleading change with this client. You're trying to find ways of getting your foot in the door to prove to him that he's got a drinking problem. So one day I happened to be in a good mood, which doesn't happen very often when you live in Colorado. And I'm just kidding. I'm just trying to get you to laugh so you'll hear the next part. But I was in a good mood, and I started congratulating him for the way that he would slam the door in my face. And I said, you know what? You're really good at closing the door in my face. And he looked at me like, what? What are you talking about? It's like, and so I said, and I started gesturing. I was like, no matter which way I come at you about your drinking, you close the door in my face. And then I started thanking him and affirming him. And I said, but I noticed that when I try to get my foot in the door, you don't slam the door on my foot. So thank you. I appreciate that. And then, he's like, what, okay. And the interview ends, and he goes away, and as far as I was concerned, it was a loss. But the next interview, he comes in, and about 20 minutes into the conversation, he says, did you notice anything? And I said, what? And he said, I'm not slamming the door in your face today. I said, I did notice. Thank you. And thank you for pointing it out, too. What's making the difference? Yeah, and what's making the difference? Getting him to talk more about what was the process. He obviously went away and thought about it. He thought, she's not so bad. Oh, I don't have to do that to her. Oh, that poor girl, she's working so hard. Who knows? So he let me put my foot in the door a little bit. How to work with a client that's not compliant. So let's see, what kind of ideas are you getting so far from the motivational interviewing point of view of ways that you could massage that conversation and elicit some narrative or some material from the client that would give you some clues about how to take things to the next step. So let's say they're not compliant with taking their medication, or they're not compliant with managing their food plan, or they're not compliant with physical activity. What do you think? Well, first of all, let's do the assessment. If they're not compliant, by definition, after you've had this class, you know that they're ambivalent. You got the answer. So tell me something that you notice that your clients aren't compliant about. And then I'll use that as an example of some way to work with it. Exercise, which we're now going to call for the rest of our life. How did Dr. Ludwig say it? Okay, see, my brain didn't like it, so it just popped out of my brain. They say that ideas that disagree with the way that we think are harder to learn than ones that we agree with. It's really true. So physical activity, although I'm sold on physical activity. So either monitoring their insulin or their glucose and or physical activity. So John, how have you done with, last time we talked about ways that you could increase and begin sort of in a small way having a program of physical activity in your day. And then what does Juan say? No tengo el tiempo. I don't have the time. Oh, so you don't have the time, I know. Oh, a lot of those things that people say like that, by the way, another way that I'll respond to it is in a sympathetic way. Because don't we all identify with not having time? Yeah, I know, it's really rough feeling like you don't have the time. And then if it's appropriate, I might do a self-disclosure. So for instance, my physical activity is swimming. And so I'll say, I swim for my exercise, but I noticed that I pretty much have to do it before noon, because after that my motivation starts going down the drain. So you sort of put yourself in there as a person who's also working on themselves, and a person who's also ambivalent about working on themselves. So I say, oh yeah, I know, it's really rough when you've got a lot of things in your day. And then you look at Juan, and he's probably looking at you in a slightly more positive way, because you didn't show that you were disappointed or you weren't judgmental or anything like that. And then, so the fact that you say that makes me think that you probably thought about it, but you probably feel two ways about it. And then I look at him and he's kind of looking at me like, what? Well, what I'm thinking is, so then that's my sort of green light to explain myself a little bit more. Because, with some of our concepts, like in diabetes education, they may be so familiar to you that I don't know if you've had the experience of, this happens to me, where something is so familiar to me that I think everybody else knows the same thing that I do. And then the next thing I know is they're looking at you like, what are you talking about? So that's fine. You say, oh, no, wait a minute. Let's back up here. So what I mean is it sounds like maybe there's a part of you that wants to get some physical exercise and part of you that doesn't. Well, how about, and then if they say, yeah, well, and which way would you say, which is the big, then you can actually ask them next little foot in the door, well, on a scale from 1 to 10, what % of you wants to and what % of you doesn't want to? So how would you rate the part of you that doesn't want to on a 1 to 10 scale? And they say 6. And they say, how would you rate? So that means the part of you that wants to is a 4. Great, that's sort of the way I thought about it too. Well, what about, so it sounds like, what is it on the not doing it part that makes it hard for you? And so they tell you what makes it hard. Meanwhile, you're building a collaborative relationship. You're giving them permission to whine to you, if that's what it is, about everything that makes it hard. But you don't care because you're getting very useful information about the what that we talked about before lunch. Starts with an O. The obstacles that are keeping the person from taking the next step. So the good news about obstacles is there's really kind of like 4 main obstacles. There's behavioral obstacles where the person may not know how to do what it is that you're talking about. That's an easy one to overcome. And when they tell you what makes it hard, then you'll know. If it's a behavioral, just going to the rec center can be kind of an intimidating thing to somebody who doesn't know what it's all like there. So the overcoming the obstacle, the antidote might be, oh, well, how about if we talk about it? Or how about if we go together? Or how about, is there anybody in your family that could go with you or something? So one obstacle is behavioral. Another one is environmental. The person has environmental obstacles that are getting in the way. So Dr. Ludwig did one of the things that I thought was very compassionate about the book, besides everything else, was the way that you put it you put it in the front of the book, what the social and economic pressures, that really nice slide that you had on all the pressures on the individual that maintain the lifestyle of unhealthy lifestyle habits, so that it showed how you are taking the approach of don't blame the customer, don't blame the patient. It's understandable how the person comes to be acting the way they do, which is sort of the way I think about people. That I don't know if you guys get in, well, this is a trap that I don't talk about, but it is a trap. The trap of the person, when you say the person just wants to feel bad, do you fall into that one? Maybe that's a psychologist that fall into that one. Okay, because personally, I don't feel like anybody wants to feel bad. That's a terrible frame to have. People may be in a bad place because they don't know what else to do. So then the obstacle could be a behavioral obstacle. It could be an environmental obstacle. It could be untreated co-occurring problem, untreated depression, untreated anxiety, something like that. So those are the 3 main obstacles. There's one more that I'm forgetting. Cognitive, how the person thinks about. And so when they tell you the part of them that doesn't want to do something, they're telling you how they think about it. And so it could be that you can help reframe the way they think about it. Just like Dr. Ludwig was saying, if you think about it as exercise, that just makes you feel like, tired, exertion, tired. Oh, physical activity. You're already doing physical activity all day long. The new idea of just increase the number of times you're going up and down the stairs at work instead of taking the elevator or something like that. Okay, so then, so we talked about how in every conversation there's doors that you can open and doors that you can close. Then the 4 interviewing skills that I can't possibly practice with you here, but that are the essential foundation for the launching of motivational interviewing are open questions, affirmations, reflections, and summaries. So those are referred to, it's an acronym that's called OARS. Open question, reflections, summaries, and affirmations. So far today we've done open questions. And open questions, if you haven't had an interviewing skills class, if you just start out a question with the words what or how or tell me, you're just about guaranteed to have an open question. So what are your thoughts about the feedback you've gotten today about your diabetes? Or tell me what your reaction is to what you're hearing today. Open questions always open the door to finding out the person's attitude and intention and past efforts. Now, affirmations, we've talked about those. Oh, and I was going to tell you a really nice affirmation that Dr. Ludwig So in the back of the book, he has the 9-week OWL program. And by the way, you don't have to wait till you run into an adolescent or a child. This program is good for everybody, right? It just, you might have to tweak it here and there. But he says, I suppose you're saying it to us, the reader, but I can sort of visualize you saying it to your patient also. So Dr. Ludwig meets them at the door and he says, "Welcome to the program. We've been waiting for you and are glad you're here." Oh, now even your most kind of pissed off, resistant person, what can you say when somebody says, "We've been waiting for you. We're glad that you're here"? Oh, okay. I think I'll just be civil and sit myself down here. I was going to get into a big fight with him, but I think I'll change my mind about this. So those are the essential skills. Now, these skills are actually just Rogerian skills. You're not actually literally, technically doing motivational interviewing when you use these skills, but you can't do it unless you do these skills. But just one thing you might just take a minute to think about how much of your conversation with clients includes these ingredients. Because, for instance, when I went to the training with Bill Miller on motivational interviewing, one of the things that I took away, and I noticed that you're being asked, what is it that you're taking away that you feel that you can apply in a practical way in your everyday life with your patients? One of the things I took away is a realization that if I did an affirmation with a client, it was much more in a hit and miss sort of way. So I took it away as a goal to every single session find something to affirm in the client's attitude, which is the cognitive part of their persona, or their intention, which taps into the behavioral domain of motivation, or their efforts, which is also behavioral. So by the way, and an affirmation is not a cheerleading. It's not, "You can do it," or "You need to do this," or "This is going to be great if you do it." It has to be genuinely located within the client. Something positive that you see that they've done. So for instance, one time a client came in, a person with very low self-esteem, and her whole demeanor, you could see she was beating herself up, and she came in the door telling me that she hadn't done her homework assignment, which I'm keen on homework assignments. But then in the next few minutes, it turned out she had modified the homework assignment in a way that was a better fit for her. So then the affirmation was, "What do you mean you didn't do the homework assignment? You found a way, something that was a better fit for you, and you actually went and did it." Great, good for you. I'm glad that you felt confident, and since confidence was an issue, reinforced that you felt confident about modifying that. Okay. So now give me some examples of affirmations because you've had 20 zillion conversations with clients. So tell me some potential affirmations you can make, and then if there's any way of tweaking it, I'll let you know. So glad that you made it that one. There's certain affirmations that are universals, and that's a universal. You'll be able to use it over and over again. So glad that you were able to make it to your appointment today. Yeah. What else? Thank you for telling me that you didn't do it. That helps me. In fact, maybe what we could do is brainstorm for a minute or two. What was it that made it hard about doing it? So Jay Haley, who's a master family therapist that wrote books on strategic family therapy, he says the first thing to do when you give the client a homework assignment and they don't do it, first blame yourself or run it through your brain. Maybe it wasn't the right one for them. So then when you say, well, what was it that made it hard, you'll find out whether it was you or them. So personally, I wasn't trained in behavioral interventions, which I feel was a real minus, and I've come to it later in my life. And so what I find with homework assignments is you'll get better and better at it over time. So, okay, what else? Because I know your clients do positive things. What do you see that you can affirm? I noticed at first that you got some new sneakers. Oh, what is that all about? So you're playful. And Oh, I didn't know. It sounds like you're thinking about something. See if you can get them to do the work of saying they're at least, that's a sign of somebody that's preparing for change. That's a very good sign. Okay, and then the El Guapo had an idea? Oh, he even knows who he is. I said the handsome one, and he looked at me right away. He knew it was him. He was just being polite, of course. I noticed that you started checking your glucose levels. How was it? Very good, very good. Because that probably was operating on the level of a homework assignment, where when you left, you sort of said that would be a good thing, and let's see. And now, speaking of that, when the client does their homework assignment, go over it with them. I listened one time to a talk that this brilliant psychiatrist did in our town. He's the best diagnostician around. And when it came to homework assignments, he touted the value of homework assignments. And then he said, and I can tell you that 100% of patients don't do their homework assignment. And since I know him, I know exactly why they don't do their homework assignments. Guess why? You said it over there. He doesn't ask them. Well, after a while, you find out you realize he's not interested. The homework assignment is juicy. The client gets motivated. You put your heads together. It's collaborative. You get out. You get good medical information about how they're doing. Okay. Any other affirmations you want to tell me about? I'm so glad you took your bicycle out to go for a ride. Oh, okay, and they actually did it. Oh, wow. Okay, now, and this is way too technical for a 2-hour presentation, but the people that do what I do on the listserver got into an argument that went on for weeks, and it was unbelievably boring. But anyway, it's the issue about evoking reinforcement or invoking reinforcement. So I feel really good about the change that you make. It's okay, nothing wrong with it. Slightly better, make the praise be located within the client. Oh, wow, so you actually got your bike out and you went and exercised. Oh, how did that feel? Oh, exercised. What, am I supposed to say, you took a ride? Yeah, see how hard it is to structure those neural pathways? Yeah. How was it? And how did you, now they may say something negative. They may say, oh, I was sore as heck. Yeah, I know. And then you say, yeah, you know that's what's going to happen because it happens with you when you do something new. Yeah, that's the part that's too bad. But I'll bet you felt good that you did it. See? Because you know that they did, because you know that you do. If you do something hard, even though you have an unwanted side effect like aching bones or muscles afterwards. Okay. Now, so then the next tip is possibly the best one in this whole workshop. So we've got the 4 basic skills of motivational interviewing. Okay, now, this is something that you would normally not even get till you came to day number 4 and 5 of motivational interviewing training. But if you want to have the big picture of what the flow of change talk looks like, the client comes in, they've got their narrative, you're assessing, just like you in some of your emails you told me, you assess lifestyle, obstacles, current situations that the client has, maybe their medical history. And then remember, now we're adding another piece to the assessment where you say to the client, well, I've got some ideas about this, but I don't know if you're interested, or I've got the results of the assessment, I don't know if you're interested, so you're asking for permission, because that's going to get them involved in the process, and you're also going to get a sense automatically of their ambivalence about change. There's a really interesting study that came out last year. It was in the addictions field, but I wouldn't be surprised if it didn't generalize, that showed that clients that were given feedback on their assessments on intake at the time of the first appointment had the rates of them following through with the second appointment was higher. So, because sometimes we think all that assessment data is something that helps us, but actually it's critical to give the person feedback on what the results are, because it's got the potential for increasing motivation for change. So then, since we know that the 4 signs of motivation for change are if the client expresses desire to change, ability to change. Ability means confidence, by the way. They really should have the word confidence, but if you're trying to work out an acronym, which the motivational interviewing trainers are extremely keen on doing, and it's like, please, not one more acronym. But anyway, this one is actually, this is new material. This is not in the second edition of motivational interviewing, but it is in this edition of motivational interviewing in healthcare. So these are the 4 clues that tell you that there's motivation for change. So what we know in social learning theory is that once you know that something works, then don't wait for just randomly the client to express desire, ability, reasons, or need to change. Actually ask them questions that would elicit and double check, assess, is there any desire, ability meaning confidence, or reasons or need to change? Okay, somebody said they gave them feedback on their the results of their medical reports, and they said, what do you think is the next step? And the client said, I'd like to lose weight. Is that an expression of desire, ability, reason, or need? Absolutely. Oh, so then reflection. So remember that the 4 skills are open questions, affirmations, reflections, and summaries. Oh, sounds like you've thought about it, and that's something that you feel that you'd like to start with. And then guaranteed they're going to say something back, and then you're going to reflect that back. Now here's your foot in the door. So maybe they say something, but it's kind of neutral. And then, so then you can follow up with an open question to elicit reasons. Well, from your point of view, what might be some of the reasons that losing weight would benefit you? You know, we know academically what the reasons are for losing weight if you're overweight, but for that person, what are they looking forward to? Because when they tell you the reasons from their point of view that losing weight might be good for them, they're giving you information that in motivational interviewing adds up to starts with an I, and the second letter is an N. And the last one is an S. Not too bad, not too bad. Keep going over there. Third one is a C. The incentives for change. The incentives for change. So if you come to the 3-day training, I'm sorry to stretch you out like this, you'll start to see how these pieces all fit together really nicely, that there's more than one way that you're going to find out the incentives and the obstacles. So the person says, I'd like to lose weight. Wow, sounds like you've thought about it, and you have sounds like there's a desire to take a step here. Oh, well then, from your point of view, what might be some of the reasons that you have in your mind that losing weight might help you? And then they give you their reasons to change. That's their incentives to change. I'm going to write that down in my notes, because then in the future, in every single conversation, I'm going to bring up the incentives. So every single conversation, you do an affirmation and you mention the incentives. So what might some of your real patients say that is a motivator for them to lose weight? In what way do they think it would help them? I'd feel better about myself. Great, that's really worthwhile. What else? And then, you keep going until you feel like you're running out of steam. Okay, so then the next one, ability, you put this one on a 10-point scale. So there's 3 questions. So this one you're going to elicit from the client. So on a scale from 1 to 10, and you've got a slide on this down the road here a little bit, but on a scale from 1 to 10, how confident do you feel about your ability to lose some weight? And they say whatever it is. And then you say, oh, okay. And then on a scale from 1 to 10, how important is it to you? In fact, I said it in the wrong order. The first question technically is importance. So on a scale from 1 to 10, how important is it to you to lose weight? And then they say whatever it is. And sometimes the client will say, well, it's a 6. Yeah, that's sort of what I thought it was for you too, based on the way you were talking. So see, you're just being like two friends talking to each other in a conversation. You're being very friendly, collegial. Yeah, that's what I thought too. Or another thing that some clients with low self-esteem, they'll persistently rate themselves low. So maybe they'll say, well, it's really important to me to lose weight. It's a 7. Oh, wow, okay, that's great. And then on a scale from 1 to 10, how confident are you about your ability to make that change? And they'll say 2. Okay, and then on a scale from 1 to 10, third question, how committed are you to begin taking some steps? Not to lose 100 pounds, but to begin taking some steps. Now, here's an important one. In the field of what they found is that self-efficacy, so in motivational interviewing, the authors are behaviorists, so the concept of self-concept is not a behavioral measurable term. So they use the social learning term self-efficacy based on the work of Bandura. Self-efficacy is how confident, self-efficacy means confidence. How confident are you on a scale from 1 to 10 in your ability to make a change? Well, they've done some research that showed that the number one predictor of whether a person will make a change or not is not whether they're motivated, not whether they're in denial, not whether they've hit bottom, not whether they're compliant or not compliant, but is actually whether they're confident about their ability to do it. And then confidence is not enough either, because that's not behavioral. So Bill Miller isn't happy till he gets all of his tools down to a really practical level. Confidence is ruled in by having the skills to make that change. So in your setting, it might be having the knowledge that you need to make that change, like knowledge about how to do, like knowledge about how to monitor your glucose levels, or having the skills to do it. So if people know how to do something, they're much more likely to do it. So for instance, if you said to me, Michelle, on a scale from 1 to 10, how confident are you about your ability to ski down the diamond slopes? I might say 0. Okay, now here's another improvement. If a client says 0, in a very friendly way, you say, no, to be alive is to be at least a 1. And so they react just the way you guys just now did. You see, like, the client's feathers getting kind of fluffed up. Oh, I'm a 1? Oh, okay. Because it's true. To be alive is to be, you've got to be motivated to be alive. So to be alive is to be at least a 1. Oh, okay. Well, then I'd say, well, I'm a 1. And then, but Michelle, how important is it to you to be able to ski down the diamond slopes? 1. And how committed are you to your skiing down the diamond slopes? 1. What's the probability that I'm going to ski down the diamond slopes? 0, yeah. And is it even worthwhile trying to motivate me to get into a class? No, because it's not important. So when you say to the person, how important is making this change for you? If it's not important at all, don't be surprised if they don't make the change. But the other thing is, if they say that it's important, but their confidence level is low, juicy clue that there's obstacles in the way. And you just in the back of your mind know that they're probably either behavioral obstacles, cognitive obstacles, environmental obstacles, or untreated psychiatric conditions like depression or anxiety or something like that. I'm too depressed to get myself up and going to go somewhere. Here's the best part of the whole workshop. This is how you do a brief intervention in your jobs. So a brief intervention, remember that I said, is every single conversation that you have with a client, you can think of this is a standalone intervention. What would be the best of the best of the best that I could say to this client that if I were only going to talk to them one time, how could I package this in a way that increases motivation and reduces resistance about taking a next step? And this is something that they found. There's been a whole bunch of studies on this. One of them was with doctors in emergency rooms. You probably know this one. In my opinion, doctors throw away their power amazingly. To put it in the positive frame, doctors can be amazing agents for change agents, because the patient really, 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 really pays attention to what the doctor said. Now, they may shine it on or, try to fluff it off or be an ostrich about it, but they really do listen. So doctors can be a lot more influential in the change process. So they found the first study of this was done with doctors in emergency rooms, where they trained doctors to give patients who are leaving one piece of advice to follow through with one healthy thing for themselves. And it usually was a referral to go see someone. And they found that if the doctor gave just one piece of advice, the rate of follow-through was something like 40%, whereas the baseline level of follow-through was more like 0%. So then the researchers got excited and they thought, wow, if that's that effective, how could we make this sandwich even better? So it turned out Bill Miller sent his graduate students into the library to find out and because this was right around the same time that brief interventions were all the fashion and managed care and everything. And they were trying to make us all do brief interventions, which was very annoying. But now that they don't make us do it anymore, I think they're pretty good. So you can see that my oppositional defiance after thousands of hours of therapy is completely unchanged. But they found that if doctors give feedback, and this is not to say to you, you have to do more in your jobs. This is just like in a 5-minute conversation. That if they so say like in the hospital, you have your discharge conversation, or you're exiting your end of the interview conversation. Those are great times to do what we call a frames. So a frames is a way of packaging or summarizing an interview with different ingredients that have been found to be motivational. So it turns out when Miller sent his graduate students to the library, they found that number one, getting feedback in and of itself is motivating. So that's why you say to the patient, I've got some ideas for you, but I don't know if you're interested. Or you went to the emergency room and you thought that you were having a heart attack, and they ran all these tests and it turns out that you're having a panic attack. And so the health professional comes in, they give you feedback on the test that they ran and tell you it looks like a panic attack. So they tell you what it is. But they preceded it by saying, I have the results of the test, and then they say, would you like to hear the results, or are you interested? And so then the patient says yes. Then you give them the benefit, then you give them the feedback. And then after you give them the feedback, you ask them an open-ended question, and the open-ended question is, what are you thinking about this? How do you feel about this? How are you reacting to this? And then the client tells you how they're reacting, and what do you do? If you find a way to affirm it, great. And if not, something that starts with an R. You reflect it. You summarize it back. The good news is when you do a frames, you're summarizing things. You don't have to try to change. I mean, you don't have to put effort into trying to get the person to change. So even if when they say, well, this is just a crock, I don't believe this, then you don't try to change it, you just reflect it. Oh, so it's very hard for you to see that this might actually apply to you. Then you go on to the next step. Because, see, it's not a change conversation, it's a summary conversation. The change conversation is juicy and more pithy, takes more time. You have to assess, explore, agree. This is a summary. So then the next piece is emphasizing responsibility, which when I do this with probation officers, I hate it because it's not meant the way they take it. It's not, you've got to take responsibility. Not like that. Probation officers, it just makes them so mad that the client doesn't take responsibility. They've got to take responsibility. No, not like that. It's much more light-handed, where you say to the patient, it's up to you whatever you decide to do, or it's up to you to decide to do something. That works like a charm with somebody like me, oppositional defiant. Don't tell me to do something, tell me it's up to me. Those of you that have adolescents, maybe if you don't get anything else out of today, try that one. It's up to you, you know. You can go out this weekend and have fun with your friends if you get your homework all done, but it's up to you. And then your adolescent, wah, Mom, you're so awful. Rah. Well, it's up to you. Instead of getting into a struggle about it, punctuate it. Then, piece of advice. Now, don't get all excited with your invisible helper hats. The advice isn't what you're going to think either. Advice is, in this case, is very light-handed, generic, superficial, where you're using what we call in supervision your referent power. And you say, I hope you do decide to do something about this. Advice, I hope you do decide to take a step. So see, referent power, that's one that doctors could use a lot more, that just, you don't have to make, it's just a very minor chiropractic. You already have the referent power. Referent power, by the way, is your likability power, or the power that you have by virtue of the fact that somebody's looking up to you. Another kind of power that you have is expert power. You know, some docs aren't very likable, but they don't have, is that what you were thinking over here? The referent power isn't there like that, but they have expert power. So I'm going to forgive a doc that doesn't have referent power. I don't care. I've got friends that have referent power. If you have expert power, I'm going to appreciate it if my tummy is hurting and you show me that you've got expertise in that area. So then you say, I hope you do decide to take a step here. I could tell you a story, but I think I better not, about a doctor that didn't use his referent power. In fact, he recommended a procedure that I didn't want, and he said it in a sarcastic way about something about, in your condition, you should be doing such and such. And it's like, what? It was worse than that even. But anyway, I didn't do it. Unfortunately, I should have done it. And 2 years later, I should have done it 2 years before. But I'm not remember exactly what it was. That guy had no referent power at all. But the thing about it, he was so unbelievably bright that it was kind of a treat to talk to him. You could insult him like mad, and he was like, no problem. He would just roll with whatever you said to him. When I get nervous, I fight, and it's one of my less attractive qualities. I got so carried away by him giving me feedback I didn't want to hear that I ended up telling him that he was acting like that with me, bossing me around in the conversation, because at home he didn't have very much power in his... I'm ashamed of myself, and I'm sure I insist on going to hell a little bit for that. But the hilarious part is he just laughed, and he said, oh yeah, that's probably it. This guy was so smart that he's like the guy that's always been the top of their class, and like people just can't keep up with him. So, and he had a lot of charisma too. So, and he was very guapo. So, Okay, so advice is light-handed. Then, what about if we brainstorm some ideas? So, okay, now this is the one that's probably going to help all of you who sent me your we call your stumper statements. What about if we brainstorm some ideas for things that you can do to take a next step? People feel more motivated for change when they feel that they have a menu of options. So instead of, well, what about, somebody said, well, what about instead of eating 5 pot pies a day for breakfast, you stretch it out through the day? Well, instead of that one, how about if we brainstorm this was the same person that said, I can't eat a healthy diet because I can't afford it. Well, how about if we see, that's a door that you don't even want to get into, probably. Not guaranteed, but, well, how about if we brainstorm some ideas about, because you said you wanted to lose weight, maybe we're on the wrong track here, but maybe if we brainstorm some ideas about what you think might be the next step. And you'll be agreeably surprised how often clients do have some ideas that would be workable for them. Okay, so the next ingredient is always, empathy is always defined as reflective listening, and then the S is always trying to find some way of boost self-efficacy. So here's the way this might look in real life. Well, Miss Sally, I'm glad to see you here today because I missed you in the last 3 times that you called in to not make your appointment. What made it possible for you to get here today? So you stay away from the content. How did you manage to get here today? You go with the process. You find out what that might have been. Oh, great, good for you. Now you're kind of stroking your kitty and scratching their ears. And then you say, well, I've got the results of your test. I don't know if you're interested. Yeah, that's why I came in. Great, well, blah, 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 blah. You guys know, I don't know how to do it, but you guys know how to give the feedback part. So what do you think? Oh, this is really shocking. Oh, so then reflection. Oh, so this really came out of the blue for you. Yes, it did. I didn't know it was that bad. Oh, and the way that you're reacting, what does this mean to you? Oh, my dad had cardiovascular problems, and I saw him in the hospital after surgery, and I thought that was a very scary experience, and I wouldn't want that to happen to me. Oh, so that's a real motivator for you. Yes, it is. Well, yeah, I'm sorry that you had that experience, but it sounds like it really stuck in your mind as something you didn't want to see happen. No, I don't. Well, how about if we brainstorm some ideas about things that might help you right away? Menu of options. And then the client says whatever they say, you reflect it. Okay, well, how about if next time I check in with you on how you did? And they say, okay, so great. I think you can do it, so we'll have to see what happens. That's the end of it. So I just did that like that to show you just very briefly that it's not something that you have to spend a lot of time on. It's just a way of punctuating what you already do with your conversations, but putting in some motivational ingredients. They found when the docs in the emergency room gave the referral, the discharge summary, conversation with a client, and they included the 6 ingredients, the rate of follow-through with the referral went from 40% to 60%. So compliance rates go way up. And by the way, motivational interviewing that's where motivational interviewing has been shown to be effective, is it increases rates of client engagement, showing up for the first appointment, client retention, showing up for all their appointments, and then client compliance. So the more the client shows up on the process level, the more they show up for the first appointment, the more they come to all their appointments, and the more that they comply with what they're supposed to do, the more likely it is that you're going to have a positive treatment outcome. Okay. So, this is a narrative that somebody sent me of a conversation. I'm going to test you here a little bit. So they explained to me that on the first visit to the client, you do the assessment, you check their lifestyle, challenges, barriers, And then the P stands for provider. The provider says, based on the information I've given you, what do you think you want to start with? Okay, conversation is already askew. Provider is already not managing the conversation. Provider is already opening a door that you'd rather keep closed. So what's the problem in this statement? Where is it going askew? You're assuming that they want to start. Absolutely. So the person is unconsciously cheerleading change or voting. The provider is advocating for change or advocating for no change or being neutral on the subject. They're implicitly advocating for change. So then we're not surprised if the client then does what? Starts digging in and say they can't do it. Okay, so instead I have the results of your test. Would you like to go over them? We've given that example multiple times. And then how are you reacting to this feedback? We've done that one. Client says, I want to lose weight. We've done that one. Great, good, sounds like you've thought about it. Then finally, what kind of ideas do you have about how you'd like to take the next step? So what you've done there is you've got the client narrative, you've reinforced their desire. Oh, and then how would that look if you were to do a frames? Okay, so sounds like, here's the results of your test. You've told me, now I know about the desire. So you really do want to do something about this. It's going to be up to you to do something, emphasizing responsibility. But I hope you do, because it seems like you are energized about this feedback. And maybe next time we can talk about what some ideas might be about how you can do it. So what do you think? And they say, yeah, okay, so we'll talk tomorrow, or whatever that might be. So you summarize the feedback. How many of you are familiar with the stages of change? Quite a few of you. And one of the things that's not in the motivational interviewing book is the 3 easy questions that you can ask that will help you find out what stage of change the client is at. So the 3 easy questions are, what is your attitude about making this change? What kind of intention, question number 2, what is your intention to make this change? And then question number 3, what kind of things have you done before to make this change? And so then the client starts telling you whatever it might be. What you have here is different strategies for different stages of change. Because I'm having to finish, let me just say that if you're interested in how to better manage the process of a conversation and you want to read some more about it, then what you would read is this book on motivational interviewing by Bill Miller. Now, if you happen to have been to other presentations and you were introduced to the stages of change, the strategy that is designed to guarantee that you will use the client's energy for change rather than your energy for change is the stage of change model. So in the stages of change, you identify what stage of change the client is at, and you tailor your intervention to that stage of change. So for instance, a contemplator, you help them contemplate change some more. The pre-contemplator, you can Google World Health Organization questionnaire on diabetes worries or something like that, and it'll come up with this 10 or 15 item questionnaire of things that you can ask people, because it turns out, here's the last tidbit of the day, very few people are real pre-contemplators. The vast majority of people who have been given feedback that is alarming about their condition are going to at least think about it. So you can always try to get your foot in the door with a pre-contemplator by saying, people have worries about their, once have been given this diagnosis, and I wonder what kind of worries you have. that's gonna, so you ignore that I'm fine or there's no problem here. You acknowledge that, you validate it, I'm glad that you're feeling great, but I'll bet you've got some worries about it. They feel okay, but the other side of the ambivalence is, but when am I gonna start not feeling okay? So, and that might be your way of getting in the door. So maybe you might say, so you're feeling okay, and I'll bet there's a little part of you that's worried about when are you gonna start not feeling okay? And if you get a green light that, yeah, there's a part of them that thinks that, then, well, what kind of worries do you have? And then once you know the worries, you can start working to remove the obstacles. So I've got to stop. Thank you for inviting me here to Watsonville, and may the following year find that you've stamped out diabetes in the county of Santa Cruz.
I'm going to share with you some information that a group in Santa Cruz has been working on for the past couple of years, and we have decided to call ourselves the Santa Cruz County Health Equity Group. So this is a presentation that we have been slowly building over time, and it's still a work in progress. This is titled Place Matters in Santa Cruz County. In thinking about what we heard about in the morning and this afternoon, this piece of the day is really not going to be focused on individual behavior change. It's really going to talk about what do we provide in our communities and our neighborhoods to make it easier for people to make the right healthy choice. But I think it ties in really well with what we heard earlier today. One disclaimer I'm going to make is the data that we have was based on Census Data 2000 because the updated 2010 data had not come out. And I know this trips some people up. What I'm going to ask is that you just hang in with us. When we get the updated 2010 data, we will be hopefully updating our maps. But what we do know is things have just gotten worse since Census Data 2000 was gathered. So we know that. There's a common assumption that the individual's health status, how healthy we are, is mostly determined by the medical care they receive. Today we want to test that assumption by discussing how other factors, for example, where you live, can have a greater impact on your health than health care. So the group that I was talking about is a group of people from a bunch of different agencies, the Community Foundation of Santa Cruz, Santa Cruz County Health Services Agency, Health Improvement Partnership, Watsonville Parks and Community Services, Watsonville Law Center, Live Oak Family Resource Center, Women's Health Center, and Central Coast Alliance for Health. We've been meeting together for approximately 2 years, 2.5 years, and we decided that it was time to look at local data. And so we got data from 5 years worth of death certificates in Santa Cruz, 2003 to 2007, and we looked at 4 indicators specifically. We looked at address, age of death, cause of death, and ethnicity. Where we live, what we eat, and what we do have more of an impact on our health than access to doctors or genetics. So this particular slide is from an article published in the 2002 Health Affairs Journal and shows that individual behaviors such as smoking, the food we eat, and lack of exercise account for 40% of poor health outcomes, as compared to 30% due to genetics and 10% due to access to medical care, or lack of access. Sometimes barriers to healthier decisions are just too high for an individual to overcome, even with great motivation. Another disclaimer, I apologize to people from Monterey and San Benito counties, but this is the Santa Cruz County data specifically, and one day we'll move on and get San Benito and Monterey County data as well. All Santa Cruz County residents do not have the same opportunities to make healthy choices. Where people work, learn, and play has an enormous impact, whether they stay well in the first place. Health starts in strong, loving families and in neighborhoods with sidewalks, safe for walking, and grocery stores with fresh vegetables. Some people live in neighborhoods where there are more alcohol outlets than stores with fresh produce, or live in housing that's full of mold, which can lead to asthma. And in some cases, especially we see this in Watsonville, there's overcrowding, which can lead to poor health outcomes as well. So the concept of health equity. Health equity means everyone has the same opportunity for health, regardless of race, income, education, or where they live. And health equity requires widening our lens to bring into view ways in which our jobs, working conditions, housing, social inclusion, and even political power influence individual and community health. I'm going to start with our maps. This is a map of the County of Santa Cruz, and the color scheme is based on census tracts and life expectancy. Our first slide is life expectancy. You know, even though Santa Cruz County actually is a pretty healthy county overall, our lowest life expectancy census tracts are down to like 75 years. We still see a 10-year discrepancy in some of the census tracts. If you look, on my screen it shows up yellow. You'll notice that those are the lower life expectancy census tracts, so between 75 to 78 years, with the brown as high as 88 years. I'm going to lead you through a couple of different maps that show a couple of different indicators. The next slide is a map of the median household income, and you'll see that the green is as low as 31,000 to 41,000 household income, with the brown as high as 100. And once again, we're using 2000 data, so we know that this has changed and probably gotten dramatically worse. Our next map is high school education. Once again, notice in the green areas, we see 35 to 60% of residents there have high school education or more, with the brown areas up to 100%. Unemployment, once again, we know that this is worse than when we got our data. In the green areas, it's 12 to 24%. We know in Watsonville it got higher than 25%. And in the brown areas, less than 4%. And then once again, back to life expectancy. So you probably saw some patterns emerge from those maps. And our question is, as I said before, even though our county in general is a healthy county, is it acceptable that there are some census tracts where people live 10 years less? I'm going to show you some pictures from the 3 low life expectancy census tracts, and then also finally with the higher life expectancy census tract. So this is a low life expectancy census tract in Live Oak area, which for those of you who are not from this county and may not know is a mid-county area that's a changing community. And even though some of these homes look nice, we see that there are a couple of streets with no sidewalks or bike lanes. This is a home, a fairly dilapidated home next to a brand new home, and that's something that is common in the Live Oak area. So this is where that census tract is. You can see it's right off of Highway 1. So the life expectancy is 75 years with a high school graduation rate of 78%. Poverty is at 9%. Median household income, $53,000 approximately, and owner-occupied homes, 59%. I am looking forward to the 2010 census data because I know that we're going to see some differences. This is the low life expectancy census tract in Watsonville, where one of the things that stands out for me is there's no greenery on the streets. There's no trees planted on the sidewalks. You know, people are trying in their front yards, and the homes, you know, even though they're not completely dilapidated, they're not as nice as some of the nicer homes we saw in the Live Oak. And this is where that census tract is located in Watsonville, with a life expectancy, once again, of 78 years, high school graduation rate of 38%, poverty rate at 26%, median household income of $32,500, owner-occupied homes 21%. And the next low life expectancy census tract, which comes as a surprise to some people, is Ben Lomond. You know, and when I look at these pictures, my first thought was, wow, how beautiful. But then when you put on your health equity public health lens, you say, wow, if I wanted my kid to walk or bike, I wouldn't let them do that there. If I didn't have a car and I had to take the bus and it's raining, that's going to be a bummer because I'm going to get wet. And a friend of mine who lives in the valley commented that all of the bus stops along Highway 9 do not have any protection whatsoever. So what does that mean for the people who live there that don't have a car? So, you know, part of this health equity stuff is kind of digging in a little deeper than what we normally immediately think of. So here's the information for that census tract. Life expectancy of approximately 77 years. A higher high school graduation rate of 93%, poverty at 9%, household median income about 56%, and owner-occupied homes 68%. This is the Soquel Hills. This is our high life expectancy census tract. So you can see it definitely does look different. But the question is it fair that these people live 10 years longer? So 88 years, high school graduation rate of 97%, poverty about 5%, median household income, I'm sure it's greater than 100,000 now, and owner-occupied homes, 81%. Many of you may recall from high school and college the story of Sisyphus, the Greek king who was doomed to push a boulder up the hill only to have it roll back down as he neared the summit. Sounds like dieting to me. And based on what we heard earlier today, I was like, yep, that's right. This myth or image is very important when considering our health, because for decades, public health's traditional approach to health promotion didn't address the community environments people have around them when they try to be active and eat healthy. They only focus on messages to the individual, programs focused on the individual. And there was almost no change in the population level behavior. Now evidence is mounting that a major contributor to that frustrating lack of success was barriers in the community environment that make it harder for most people with ordinary motivation to sustain better health behavior. We seem to be making progress now that we understand it, and we're making healthier choices easier so people can progress more towards their goals. And I know, in Santa Cruz County with our Regional Diabetes Collaborative and with the Go for Health Collaborative, we are trying to work on making environmental change strategies so that we can change the environments. But it's, as you all are very well aware, it's a long, slow process. One thing that we do have control over that Sisyphus never could consider was the hill. The grade of the hill can impact our behavior. This incline can make health a task or a lifestyle. The hill is comprised of the many barriers to achieving behavior change. Once you alter the hill, then you can make it easier to start, maintain, and sustain a healthy lifestyle. It's important to move to a combined community and individual focus, both. The goal is to remove the barriers in the community environment to make it easier for everyone to make healthier choices. With a flatter incline and fewer barriers, it becomes easier to make health part of our daily routines. So if we have fruits and vegetables that are not only accessible, but are affordable, then, people probably will make that choice. We all want, I think it was last Friday at Bill Monning's press conference, one of the things he said, which resonated for me, is as parents, we all want the best for our kids. We all want the best for our kids, and if we have the opportunity to make that choice, we're going to make it for them because we want them to do well. The question that we're left with is, what do we do? I mean, if we know all this, we're becoming more knowledgeable about making those changes at the community level. So what do we do? And here's a couple of suggestions. One thing we can do is build strong local neighborhood groups that can mobilize communities for action, such as neighborhood watch groups. For example, the ones that came to my mind were in Santa Cruz, the Neighbors of Lower Ocean Street. There's Take Back Santa Cruz, and Santa Cruz Neighbors. They've done a variety of different activities to try to just become more present in their neighborhood and more aware. My coworkers told me yesterday that on Lower Ocean and Barson, the Neighbors of Lower Ocean Street actually worked with the city to change one of the alcohol outlets down there to, not that it's a little bit better, a pizza place, but it's not alcohol. Engage residents and build their skills to speak and act effectively, and unite advocates to educate and influence decision makers. And we all know this, I know you all know this, a lot of our disenfranchised communities aren't aware that they could have a voice. And that's something that we as healthcare providers and educators can help them with, that they actually do have a voice, and if they unite in community groups and learn how to go to city council meetings or school board meetings or board of supervisor meetings, that they can be heard. Some examples of what's happening in Santa Cruz County, and there's been a lot going on in Watsonville. Watsonville is improving park safety through the policy and advocacy work of Jóvenes Sanos. There's been a number of increase in farmers markets around the county, and what's also exciting is that farmer markets now can accept EBT cards. So that's also really exciting, although sometimes they are more expensive, so that's a trade-off. More bike lanes and sidewalks to make walking and biking safer and encourage people to get out of their cars. And Watsonville recently passed an ordinance to increase healthy food options at restaurants. And Live Oak area is actually adding more parks, which is also going to be helpful. In terms of what we can do on behalf of within our agencies, there's a couple of different things that agencies can do. They can invite our group, for example, to your agency to discuss this presentation and begin a dialogue about what is health equity and how can we start to change internally in our agencies to address health equity. And that can sometimes include encouraging your clients to advocate for themselves. Implement trainings at your agency that help your staff understand the concept of health equity. For example, the connection between race, class, gender, and health. And ensure that your agency has diversity at all levels of the organization. And I'm sure that there's a lot of other ideas, and we're still working on trying to come up with other ideas. We want to begin this dialogue with not just providers, but we have somebody who works with promotoras who is taking this out to her promotora groups and have them share it with their community, as well as some of you are aware of COPA, which is works with the churches, and they kind of are an advocacy group, and we have a health committee in COPA that is also working on this and sharing this. So basically, all policy is health policy. Generally, we do this in conjunction with a PBS series called Unnatural Causes. Some of you may have heard about it. There are, I think, 7 or 8 half-hour episodes that were aired on PBS and were funded by the Robert Wood Johnson Foundation to start to get people to think about how policy has impacted the health of our communities. They also talk about how race and racism impacts the health of our communities. So anyway, I encourage you all to look at or watch those DVDs. You can borrow them from the Community Foundation of Santa Cruz County.